Hi there. So my name is Laurie Myers, and I have had the privilege of leading Merck's health literacy work for the past 6 years. And today I wanted to talk to you about one of our most important projects, which is the development and the testing of health literate patient labeling, specifically with the focus on the inclusion of respondents with low health literacy. So to give you a sense of what I'm going to say, in short, it's important to include respondents with low health literacy. It won't happen by accident. You have to really be thoughtful and make sure you do it in a systematic way, but it will really give you a product that's much, much better based on the insights that you will hear. So the overall goal of this project is to maximize the comprehension of patient labeling for all audiences, including those with health literacy. We knew we wanted to do this a number of years ago, but we weren't quite sure how. And so at HARC a number of years ago, I had a great discussion with Ruth and with Mike, who of course have been doing a lot of research around best practices in the communication of labeling. And I had the privilege of leading a cross-divisional group at Merck. And it really does take a village to move something of this nature. And so it was everyone from our attorney who believed that it was possible to be both clear to patients and follow the letter and the spirit of the law, to many others across the company. And you have to start somewhere. So we started with new molecules, right? This isn't about looking backwards. This is about looking ahead and proactively developing health literate labeling for new molecules. So I want to start by saying comprehension testing of patient labeling and the development of patient labeling is something that has always been important to our company. And we had included respondents across a range of education levels. And you don't know what you don't know. What we realized after we began to include the newest vital sign in our testing is that actually, even if people didn't necessarily have high levels of education, mostly people that were volunteering for internet research about reading labels had adequate health literacy. So we had to actually put in place different health literacy assessments to make sure that we had people with low health literacy in our panels. The few that we did have directionally had lower scores, but quite frankly, we just didn't have enough of them to be able to make a systematic assessment. So we worked to change that. So here's the new process for how we develop and test our patient labels for new molecules. So the very first thing is our company creates the draft label, right? We have to make sure that it's consistent with the physician labeling and that it is accurate. And then we send it to Dr. Parker, Dr. Wolf, and their teams, and they give it back to us with their suggestions based on all their years of health literacy expertise. And then we review it. And the important concept there is we really try hard not to change it unless it's medically inaccurate, which it really isn't usually, unless we haven't communicated well. But we really try to honor and respect the knowledge that they bring working with people across a range of health literacy levels. So then we approve it, and then it goes back, review and approve it, and minor tweaks. And then we actually, they do focus groups in Chicago and Atlanta with respondents across a range of health literacy levels. So we accomplished two things there. The first is, sometimes there are things that we just don't know quite how to say. We already know that, right? So it might be a skin rash that we have a picture of and we're not quite sure how to describe it, or other things. And so we ask people to help us find the words. And the second thing is we see if there's anything we thought was clear and it turned out it maybe wasn't, right? And so those focus groups really help us to refine the patient label. And then again, we come back and we make changes based on that. And then it goes into our comprehension testing, which, by the way, is where we used to start after we develop patient labeling. And so I'm going to talk a little bit more about that, but we do qualitative research, the same theme that we heard this morning, with both limited and adequate health literacy respondents to try to make sure that it is well understood across a range of health literacy levels. And then we have a debrief, and then we revise it again as necessary. So again, you heard a theme throughout this morning of the importance of iterative patient feedback and listening to patients. And that's definitely something that we've heard here, patients and caregivers as appropriate. So I gave a lot of detail here, but I think it will hopefully help you see how much detail you have to pay attention to really do this, right? So the first thing is when you're only recruiting people on the internet for internet surveys, you're getting people generally with adequate health literacy. So we have a wonderful partner, Summer Research, who they went through this with us and they learned, and again, we had advice to help us as well, but they go to literacy centers, they go to senior centers, they go to other places we haven't traditionally gone to find people to participate in the research. The other thing is we used to rule out people age 70 and above. Guess what? Now one of our most recent studies, 2/3 of the participants were 65 and above, right? And you find out, why did we rule out people 70 and above? It's just how we had always done it. So again, you have to question your assumptions and your processes. And then we have a health literacy assessment. So to get people into the research, we ask the one-question screener: how confident are you filling out medical forms by yourself? But then at the end of the interview, we do the newest vital sign as the assessment, and that's what we use for our final classification. Because when you think about managing your health and managing your disease, numeracy is such an important part of that, and of course the NBS gets it that better. We also, and what's really exciting is Schlesinger is the group that does a lot of recruitment, at least for pharma, and they've actually now started adding the one-question screener to their database, and they're up to about 7% of their database having, in theory, low health literacy based on the one-question screener. We know people switch, but that was a pretty exciting milestone for us. And we aim for at least 25% of people with limited health literacy. Because of the switch, sometimes we don't quite get there, but we usually come pretty close. And of course, the risk factors for chronic disease are the same as the risk factors for low health literacy in many cases, so we really think that's important to have that. So how do we do things differently? The first thing is we do in-person research. So we don't just do online research anymore. We bring people in. And a really important part of this is you have to work with a market research company that's sensitized to what is health literacy. How do you treat people with respect and dignity with low health literacy who may not always be confident, right, in talking about medical information? So that's a really important part of it. These are kind of the soft things that make this successful. We do both open and closed book assessment, and so it's really important that without being able to look at anything, people can say, what is it for? How do you take it? What are the serious side effects? What are the common side effects? But the reality is, if any of us have a question about, is this medicine causing the side effect, we go online, right? We look. People have information in front of you. So that felt much more realistic to us in terms of how people use medication information. And again, you talk about the things we didn't know. We used to require a desktop computer to participate in our patient labeling research. Well, guess what? Most people, of lower socioeconomic status are more likely to have a phone, not to have a desktop computer. We were inadvertently ruling them out, right? And so, again, these are the things we've learned, and it takes time, right? So to find people with low health literacy, you have to start the recruitment earlier. Sometimes you may not even have the labeling finalized, but you have to think about this sooner. And it works, right? So this is, again, qualitative research in the quantitative summary fashion. But people with limited health literacy, with adequate health literacy, are able to understand this. And now when we submit our new patient labeling for new molecules, we actually provide a brief summary to the FDA of the results of this research, just to help demonstrate that we have, in fact, evidence that this is well understood. I mentioned earlier that education isn't a perfect proxy. And I love this top one, and this was about 100 people ago, but not much has changed. In general, it's true that people with lower education have lower levels of health literacy, and in general, it's true that people with more education have higher health literacy, but it's not perfect, right? So if all you do is use education as a proxy for health literacy, you're not really going to always get people with low health literacy. And the amazing thing is, of course, people with more education are more likely to have higher comprehension, but even people with even only some high school are able to understand it based on this process. The same is true of age. And so again, your comprehension, at the older ages, maybe a little less, but even people who are older are able to understand this. And you see we have wide participation across a range of literacy levels. And how we drive whether it's caregivers, whether it's patients, whether it's age, is we look at the demographics of the disease, right? So if it's a disease that's mostly in older folks, we aim to include people who are older in the research, right? If it's, we look at it for racial and ethnic prevalence and things like that that drive who we try to bring into the research. Not surprisingly, patients really love this. And somebody was talking earlier about, I don't want to be primarily looked at as a patient, that managing my disease is only a small part of my life. And so what's really interesting is you hear different reasons that people like this. So I'll never forget, maybe 2 years ago, we had market research, and a woman was Hispanic, and English was her second language. And she read it, and she actually started crying. She said, I never understand these. And if something happened wrong, I would know what to do, right? And that was very powerful. That was enough to keep us going for a long time. But on the other side of it, people who have high levels of health literacy are like, oh, I'm a caregiver of my elderly parent. I'm always spending time trying to help them understand their medicines. Or I'm really busy, and I'm just looking for the information really quickly. And so for different reasons, people really like it. And they say, I don't always keep this, but I'd be more likely to keep this and refer back to it if I had a question. And they're more likely to ask questions of their providers. The only thing we do here that is not in the current template is they also want to know more about the benefit, because informed patients want to know both the risks and the benefits of their medicine. So I don't see that happening anytime soon in the MI or whatever, but that is something that we hear, that I want to understand what this is for and why I should take it, not just the risks. So this was just approved maybe a month ago. This is Zimplava. It was our patient label, and I really do give kudos to the FDA because this has gone through and been approved by the FDA, and they've really been supportive of our efforts to try to apply health literacy principles to the development of our patient labeling. So this is it. It's 2 pages. And I think you can see a lot of, Will talked this morning about being 10 years old with white space and formatting and graphics. That still really helps. It may be 10 years old, but it's still really important. And so hopefully you'll see them reflected here. So we've taken these learnings and we're applying them to instructions for use. So instructions for use are when you have a combination product and you have the instructions for use have the pictures, right? My kid has an asthma inhaler. That's what I usually immediately go to with the instructions for use. And so we just began this year to use a very similar process in the development of instructions for use, where we develop it and get feedback from Dr. Parker and Dr. Wolf and their teams, get the input of patients in focus groups, et cetera. And the long and short of it is this is working really well. And much like patient labeling, we have to have an open mind. A simple example is we used to say swirl for 30 to 60 seconds. And what does that need? You need a watch or you need your phone. Now it's count to 45. And and again, it's not finally approved yet, so this may change, but if you count really fast, it's 30 seconds. And if you count really slow, it's 60. And that's a heck of a lot easier than a clock. Right? So it's little things like that that just are really about thinking differently and thinking innovatively. And of course, we're looking at, the work that Ed mentioned this morning. We're looking at what are others doing that are very good practices as well. And it's really working well in our initial results. Even people with limited health literacy have had much more success in measuring and mixing medicines safely. I'm not going to go into this. I know we only have 2 minutes. But just because this works in patient labeling doesn't mean it automatically works in other types of consumer research. So again, most of our consumer research is done online. The newest vital sign, there was a thing on the health literacy discussion list this week, isn't validated for online use, right? So you have to really think about this one project at a time, but it's really important regardless of what type of consumer research you're doing. And I really want to leave you with this is possible. It is possible to develop information about products that is simple and clear and easily understood by people of all health literacy levels. And you have to really be thoughtful and you have to learn from the people sitting here. So thank you.